adrenal gland. So your increase in cortisol comes from this. So your actual adrenal gland is undergoing atrophy because of this negative feedback. Okay? You can see the difference. Yeah? So if this one, there is continuous stimulation of the okay, in which the because this is from ACTH, so there is stimulation of the adrenal gland. If there is primarily from the adrenal, so the adrenal gland will eventually undergo atrophy, but you will have continuously increase in your cortisol from the adrenal tumor. Okay, so the same goes with iatrogenic prescription of corticosteroids. So if you take exogenous steroid, for example, influence effect of cortisol from this exogenous steroid, but this will cause negative feedback to your ACTH, to your pituitary. So this will eventually cause atrophy to your adrenal gland. Okay, so the danger of this, if you suddenly stop the steroid, you might get adrenal insufficiency. Okay, because your adrenal gland is actually shrinking. You are not because of not producing cortisol for quite some time. Okay, because there is no stimulation from your ACTH. So that is why, although this is temporary, okay, so that is why when patient is on steroid, if at any time you want to the treatment, it has to be treated slowly. Okay, to avoid sudden to avoid what we call sudden adrenal insufficiency, adrenal crisis. Okay, because your adrenal gland is actually atrophied. All right, understand? Okay, so clinical manifestation of Cushing's, okay, is mainly because of the effect of cortisol itself. So I suppose you all have learned this in your physiology. Okay, so the effect of cortisol on your lipid, on your carbohydrate, on your protein. Okay, so this will translate into the clinical manifestations. Okay, so I have here a few notes on this, which you can put together actually, but I want to go into this table. Okay, so for carbohydrate metabolism, okay, your cortisol cause increase in gluconeogenesis and decrease the glucose uptake. Okay, so as a result, it will cause hypoglycemia and diabetes. Okay, as for protein metabolism, it increases proteolysis. It causes protein breakdown. Okay, so it will lead to muscle weakness. It decrease in your collagen. So it will affect your skin. So your skin will be thin. So these are among the presentation of a patient with even on steroid. You know, when you want to apply steroid, you have to put only thin layer of steroid on the skin. Okay, so thin skin, easily bruising because of decreased collagen. So you imagine your blood vessels are also thin. So the superficial blood is easily bruised. Okay, as for fat metabolism, there's lipolysis, breakdown of your lipid. So on top of that, you will have redistribution of your fat to the certain, mainly at the trunk, at the central. That's why you have buffalo hump, you have moon face, uh, you have um, central obesity. Okay, so this lipolysis also is related to the stretch mark. Okay, so this stretch mark is actually due to a few things. The decrease in protein, the breakdown of protein, also it is related to the stretch. It's not like any usual stretch mark that in an obese patient who are not having Cushing. Okay, so usually, after your birth, you have stretch mark and all that. Okay, so in Cushing, is specifically it is described as purple striation. So on top of fat breakdown, thin skin, there is also bruises under that. Okay, so thin skin, so that's why it's purplish. It is purple in color. Okay, so it's the combination of increase in lipolysis as well as increase in protein breakdown. Okay, so as you all would have already learned how the steroid or your cortisol suppress your immune system. So as a result, Cushing's patients, they are prone to infections, poor wound healing. You would find suppression of other anterior pituitary hormones in a Cushing syndrome if it is caused by Cushing's disease due to pituitary tumor. Okay, depression. Okay, central nervous system effect, depression, insomnia, because that's why you need your cortisol when there is, so increase in cortisol will lead to depression and psychosis, because it influences the neuron development. Okay, so it eventually it's more on your cognitive function. Okay, water metabolism. Your cortisol has a weak mineralocortical action, so it has a weak. It can cause light water retention. Okay, because of the mineralocorticoid action. Okay, so it can lead to hypertension and heart failure. But hypertension in hypocorticolism also may be due to the increase in, a little bit earlier, we say it is increase. It increased sensitivity to the sympathetic system. Okay, so because of that, you can have hypertension if there is increase in cortisol. Yeah. Calcium metabolism, there'll be decreased calcium reabsorption from the gut and increase in calcium excretion. So because of that, it will lead to calcium resorption from the bone. So osteoporosis is one complication of steroid of Cushing's. Okay, so others. So in this patient, he has polyuria, polydipsia is disreflective of the diabetes. Okay, in this patient. Another findings that you might have is acanthosis nigricans. Okay, acanthosis nigricans are the hyperpigmentation at a certain area under the armpit, at the back of the neck. This is associated with insulin resistance. Okay, we don't know the exact mechanism, but it is said that acanthosis nigricans is associated with insulin resistance. But these are the common findings that you can see. I'm not sure whether you notice, it is more of a velvety kind of hyperpigmentation. So it looks like it looks like when you sometimes you see an obese patient with buffalo hump, and you can see at the back of the neck is blackish, so you thought it's dirty. So it's actually a acanthosis nigricans. Okay, so you can have menstrual irregularities, you can have hyperandrogenism sign and symptoms as well, due to cortisol can actually interact mildly with also the androgen receptor. Okay, so yeah, purple striation, increase in subcutaneous fat deposition, and with the thin skin, so you have subcutaneous fat with the thin skin. It's actually stretches the thin skin, and there will be ruptures of the skin, so that causes the purple striation. So this is what we're talking about. So it's not like the normal striation that you see in a patient after delivery or in an obese patient. So these are the different type of stria. Okay, easily bruising, thin skin, poor wound healing. Okay, so investigation. So this shows diabetes. Okay, all right. So this is from this patient's result. So from the baseline cortisol, okay, as you can see, the morning cortisol is high. The evening cortisol is also high. Also, it's slightly lowish, but it is actually high because you expect it to go down to less than 150. So it is expected in Cushing's syndrome there will be loss of circadian rhythm. So these are among the early signs of Cushing's syndrome. You look for the circadian rhythm. If there is loss of circadian rhythm, usually it is Cushing's syndrome. Okay, so it's not only hypercortisolism, there is loss of circadian rhythm. Okay, and urine-free cortisol. You see, most of your cortisol in the blood is bind to cortisol binding protein, right? You've learned that. So in a normal situation, almost all cortisol will bind. So when there is excess in cortisol, okay, so this cortisol has so your cortisol binding protein in a normal situation, in a normal level, most of the cortisol binding protein will be bind to the cortisol that is available. So when there is increase in cortisol, you will expected to see increase in urinary free cortisol. Okay, so it is actually a good indicator to confirm your Cushing syndrome, because usually in pseudo Cushing's, your urinary free cortisol won't be this high. Okay, so whenever you have the only problem is urinary cortisol will require 24-hour urinary collection, which can be difficult to collect. Okay, and it might be sometimes not that accurate because patient tend not to give the actual 24-hour collection. Is quite cumbersome, but actually this is used to confirm the presence of Cushing syndrome. Okay, and then serum ACTH in this patient is undetected, so it means that this is under ACTH independent hypercorticolism. Okay, so ACTH independent, so it's either because of exogenous steroid or because of adrenal tumor. So this is the pattern that you want to look for. Okay, if in the history there is no history of taking steroid or taking medication, okay, so then if you have this kind of result, you might think of adrenal tumor. okay, or adrenal hyperplasia. Okay, so it's ACTH independent. Okay, so another concept that you need to know is, first, when there is loss of circadian rhythm, Cushing syndrome, there is loss of circadian rhythm. Another concept is, if there is a pituitary tumor, okay, this pituitary tumor is partially autonomous. So that means, although it seems that when there is pituitary tumor producing ACTH, right? So it seems that this tumor will be autonomously producing ACTH, okay? But this it is only partially autonomous. So that means with enough suppression, if you want, you can actually suppress this production of ACTH from the pituitary tumor. Okay, so why do you need to know this? Because this will relate to the dynamic test that we do in Cushing syndrome. So for pituitary tumor, so if you want to try to challenge by suppressing the ACTH, okay, if the suppression is low, okay, you might, if the trigger is low, if you give low suppression, okay, you might not be able to see suppression of the ACTH, okay, but if you give a high dose of suppression, you might be able to suppress the ACTH and the cortisol if the Cushing is caused by pituitary tumor, or in other words, if it is caused by Cushing's disease. Okay. However, if it is caused by adrenal tumor or ectopic tumor, okay, so that means adrenal producing cortisol produced by adrenal tumor, or ACTH which is produced by other tumors, okay, so this tumor, no matter how much suppression you give, it will autonomously produce high cortisol. So these are the different. Okay, you get that now? Try to understand that, yeah? Okay, so this will translate into the diagnostic evaluation. Okay, so the test that we do, the dynamic test that we do for Cushing syndrome is called a dexamethasone suppression test. Okay, so what is dexamethasone? Dexamethasone are synthetic steroid, okay, which block the cortisol receptor in the pituitary. Okay, so it will cause suppression of your ACTH, which lead to decrease in cortisol. So this is what is used. Okay, so you want to try to suppress the ACTH by giving exogenous, by giving synthetic. This is actually steroid. Okay, so this steroid will bind to the receptor in the pituitary and will suppress the ACTH. So there will be decrease in stimulation of your adrenal gland. Okay, so we have talked about the upper part, okay, urinary free cortisol. So in a Cushing syndrome, okay, so it will be abnormal. Okay, so you would expect there will be abnormal. So that means the urinary free cortisol will be increased, okay, and you will do low dose dexamethasone suppression test, in which when you are not able to suppress, okay, you are not able to suppress your cortisol. So when you do dexamethasone suppression test, what you measure is you measure your cortisol. Okay, you suppress, you measure your cortisol, and you see whether your cortisol is suppressed or not. So with low dose, in all Cushing, there won't be any suppression, okay, in low dose dexamethasone. Okay, so next is you want to look at your plasma ACTH. Okay, not all lab can do plasma ACTH. Okay, so last time so some lab they because ACTH is now it is readily available, but it is not available in all labs. So sometimes you don't do plasma ACTH, but if you have plasma ACTH, it is easy in a way that you can straight away categorize it into ACTH dependent and ACTH independent. Okay. All right. So next step you want to do plasma ACTH. Okay. So let's say is plasma ACTH is low. Okay. So if your ACTH is low, so you will know that it is actually ACTH independent. So ACTH independent is caused by your adrenal tumor. All right. Okay. So you will also proceed with high dose dexamethasone suppression test. So you want to increase the suppression. You want to see with increase in dose of suppression, will the cortisol be suppressed or not? So like we said earlier, in adrenal tumor, it is autonomous. The production of cortisol is autonomous. So even if you give high dose dexamethasone, you won't be able to suppress this cortisol. So these are the results that we can get when if the Cushing caused by by adrenal tumor. Okay, if the ACTH is elevated, okay, it can either be ectopic ACTH or it can either be Cushing's disease. Okay, so it can either be these two. All right. So this is when your high dose dexamethasone suppression test makes a difference. Okay, so if you give high dose dexamethasone suppression test, if the high cortisol is caused by ectopic ACTH syndrome, so you won't see any suppression of cortisol. However, if it is caused by Cushing's disease, because we say if increase in ACTH by pituitary tumor is only partially autonomous, so with high dose of dexamethasone, this can actually enough to suppress your ACTH. So you will see suppression of your cortisol of less than 50% from the baseline. Okay, so these are the rationale of this test. Okay, is it clear? You might need a bit of time to, but I think the summary here is clear. Okay. All right. So these are the things that I've already explained to you all. Okay. So complications of Cushing's, diabetes, hypertension, osteoporosis, infections, psychosis. Okay. So the main thing are diabetes, hypertension, and osteoporosis. So because these will cause increase in mortality, infection as well. Okay. All right. Okay. All right. So can we proceed? What is the time now? Sorry, I don't have my. What? 12:30. We have. What time do we finish?
Supposedly 1:30.
Oh, and so we have 1 hour. We have another 1 hour. Okay. Kita tak banyak masa ni. Okay, any questions about Cushing so far? Can we proceed to the next one? Adrenal cortical insufficiency. Boleh ya? Okay. Alright, so next case, okay, it's already written there, Addison's disease. Okay. Okay, never mind. Okay, this case, 17-year-old girl referred to endocrine clinic, 2-month history of tiredness and lethargy. She has noticed that she's become dizzy when she stands up. So again, it's the same as what we discussed before in hypopit, right? Dizzy when standing up. Okay, on examination, she has pigmentation on the buccal mucosa and palmar creases and in an old appendectomy. So there are at a few places there is hyperpigmentation. BP is 120/80 on lying down, but falls to 90/50 when stands up. So this shows that this patient has postural hypotension. Postural hypotension. To a certain extent, I think when else that you learn postural hypotension? I think in CVS. Okay, but yes.
Oh, no, because we being exposed for the postural hypertension during pharmaco too.
All right, so you know postural hypotension, so you know the mechanism and all that, yeah. Okay, good. All right. Okay. So yes.
Can I ask a question? Mm-hmm. Why is it that both in Addison's disease and in Cushing's syndrome that tiredness and lethargy both appear over there?
Well, the tiredness and lethargy appear because of different mechanisms. Because these are very subjective sign and symptoms. It is not specific. Okay, so it can be cause of hormone. So in this case, it can also be due to loss of water. I mean, in this case there is dehydration and all that, you know. So there are a few causes. These we call it a non-specific symptoms. We can't really make out so much from just tiredness and lethargy unless we know the diagnosis. You understand what I mean? So we know the diagnosis first, then we relate it to the tiredness and lethargy, because even now I can say I'm having tiredness and lethargy as well. So it is very, very non-specific, and usually is a multifactorial. So it might be caused by the hormone, or it might be also contribution of other things as well, because in this case, I mean, it depends. Even having a tumor itself can generally lead to tiredness and lethargy. Okay, so in this case, maybe there is some anemia as well. I'm not sure whether it is in this case, but in Addison's disease, you might have anemia, you know, things like that. So it can be multifactorial. It might not point out perhaps to just hormone. Okay.
All right. Thank you.
Right. Even if it's hormone, it is related to so many things. Cortisol, as well as your thyroid. You know, it's also related to tiredness and lethargy. You see, so it is really difficult to point out to just one specific hormone which contribute to this. Okay. But of course, when we talk about endocrine, we will try our best to relate it to hormone, you know. Okay, so yes. All right, so hyperpigmentation, we'll talk about it. So because of hypotension and all that, so we proceed with further investigation. So investigation shows that sodium is low. Sodium is low. Okay, slightly low actually. Okay, potassium is high. Urea is also high. Okay, blood glucose is low. Okay, and this is a dynamic test. So at this juncture, we suspect this patient to have probably adrenal insufficiency. Okay, and we proceed with ACTH stimulation test. Okay, or synectin test. Okay, so So it shows that with so you do ACTH stimulation test, you measure cortisol. Okay, you measure cortisol. Do ACTH stimulation test, you measure cortisol. And it is found that the cortisol is not stimulated. Okay, so because at 9 hours it's 150, so supposedly after, so it started off normal, although it started off normal, so after stimulation, it is not increased. Okay, supposedly it should show at least double up the level or something like that, but this is considered not enough stimulation. So you can see if you do not do your stimulation test, you might stop here and you might say, okay, the cortisol level is actually normal. It's actually at the low range of normal. 150 is, although it falls under a normal range, it is actually quite low. It is at the lower end of normal. So this is when you need to be very, very suspicious. Okay, especially when the patient shows signs and symptoms. Okay, and this also shows with provocative test, with dynamic test, it shows that there is no stimulation after provocation. So this this sort of give an idea of adrenal insufficiency. And if you can do your plasma ACTH, you can do plasma ACTH, that helps. So in this case, your plasma ACTH is high. Okay, so low cortisol, increase in ACTH indicate primary adrenal insufficiency, right? Primary adrenal insufficiency. Okay, so further test was done, testing for antibodies. So you can proceed with a few antibodies. So it is found, so you can test for thyroid antibodies. Okay, adrenal antibodies is specific for adrenal. So it is found that adrenal antibodies are high. Why do you want to test for antibodies?
Autoimmune disease.
Okay, because this is the most common cause of primary adrenal insufficiency or Addison's disease. Okay, Addison's disease is caused by a primary adrenal insufficiency. The most common cause are autoimmune destruction autoimmune destruction of the adrenal gland. Okay, so usually you will see that there is increase in anti-adrenal antibodies. Okay, but of course you also want to check other antibodies which is related to other autoimmune disease. Okay, commonly you want to check thyroid hormone, because this patient might also have hypothyroidism, autoimmune hypothyroidism. It is also related to other autoimmune disease, for example, pernicious anemia. So it is an autoimmune thing. Okay, so it used to be TB. But nowadays, since TB is very well contained, so it is not the most common cause anymore. Okay, so TB used to be a common cause of adrenal insufficiency previously. Okay. Oh my God. Okay, so adrenal cortical. So this one, so we are discussing now specific on adrenal cortex. Yeah, adrenal cortical insufficiency, because somehow when you have adrenal insufficiency, your adrenal medulla somehow is spared. Usually it involves adrenal cortex. Okay, it can due to destruction of adrenal cortex. So this is primary, or deficiency in pituitary, ACTH, or hypothalamic. So this falls under secondary adrenocortical insufficiency. Okay, so it can be under this hypopituitarism, which we already did. Yeah. So one of the sign of hypopituitarism is decrease in ACTH, because when we talk about hypopituitarism, if you are talking about adrenal tumor, we say usually it is gradual, and usually it will affect first your growth hormone, your your gonadotrophin, then later only you will have effect of cortisol, ACTH. Okay, but in the case when you have apoplexy, sudden bleeding, sudden infarction, the effect, the ACTH deficiency can maybe the first thing that is manifested. Okay. So it can be pituitary deficiency, so it's more of a sudden onset in which you can see the effect on the ACTH in hypopituitarism. Yeah. Okay. So these are the list. Of course, so you say autoimmune about 80%. So 80% when you say adrenocortical insufficiency, you have to think about autoimmune. Okay. So others which are not common, they are not common. Okay. All right. So again, so it's the same thing lah. So I don't know why I have so many of these. Okay. So next we go to the clinical features, the sign and symptoms. Okay. So the sign and symptoms of adrenal insufficiency are different with primary and secondary adrenal insufficiency. Okay. So they have list of common symptoms, but there are symptoms that you only have it in primary, or you only have it in secondary. Okay, the principle is if you have primary adrenal insufficiency, okay, you might have deficiency in both mineralocorticoid as well as your glucocorticoid. Okay, so you will have decrease in both your cortisol as well as your aldosterone. Okay, so in primary adrenal insufficiency. If you have secondary adrenal insufficiency, so we're talking about decrease in ACTH, okay, so it only affects your glucocorticoid, okay, because your mineralocorticoid is regulated by your renin-angiotensin system. Okay, so if your adrenal gland is okay, is functioning well, okay, so if you have decrease in ACTH, only your glucocorticoid is affected. So you don't have much symptoms related to your mineralocorticoid. Okay, so that is the principle. And on top of that, in secondary adrenal insufficiency, so you might also have other signs and symptoms of hypopituitarism. So you might have symptoms of hypogonadism. Yeah? And you might have whatever that we have discussed in pituitary disorder just now, your mass effect and all that. Okay, which you might not find, you don't find it in a primary adrenal insufficiency. Okay, so that is the principle of it. Okay, so in both you will have tiredness, weakness, mental depression, mainly because of decrease in cortisol. Okay, hypotension. Okay, hypotension can be caused by loss of water, salt and water, okay, due to decrease in mineralocorticoid, okay, and if glucocorticoid, okay, if it's in a secondary adrenal insufficiency, you might have hypotension, but not as bad as in primary, because this hypotension is only because of the effect of glucocorticoid. We discussed just now, glucocorticoid have some influence on your sympathetic nervous system. So because of loss of this influence on sympathetic nervous system, you will have slight hypotension. Okay, so it's of two different mechanisms. So the hypotension in secondary adrenal insufficiency, it is not as significant as in primary adrenal insufficiency, in which you might have loss of volume because of loss of salt and water. Okay?
Doctor?
Yes.
Can the reason for hypertension in your secondary adrenal insufficiency be because of the effect of your glucocorticoid on your mineralocorticoid receptor?
Sorry?
Can the effect of secondary, like hypertension in your secondary adrenal insufficiency be because of the effect of your glucocorticoid on your mineralocorticoid receptor?
How is that?
Because I think we mentioned that glucocorticoid has a similar receptor to mineralocorticoid, right?
Yeah, but now we are talking about less in glucocorticoid.
Oh, yeah, true.
If you're talking about high in glucocorticoid, yes, you may see the effect of mineralocorticoid. In terms, we will talk about that that is actually applicable in Cushing's. Yeah, when we talk about Cushing's just now we say we have increase in cortisol, right? And it also has some effect of mineralocorticoid as well in Cushing's. So you would have sodium retention as well because of mineralocorticoid. But now we are talking about low in cortisol. So the effect is different. I mean, because in fact the decrease in cortisol is the main effect is no effect of cortisol, you know. The mineralocorticoid it doesn't actually cause decreased effect in mineralocorticoid if you still have mineralocorticoid. You understand what I mean?
Yes.
It doesn't replace the mineralocorticoid. Okay, right. Okay, so that's that. So you have hyponatremia. Okay, hyponatremia can be because of two different things as well. Okay, in primary adrenal insufficiency, hyponatremia is because you cannot reabsorb your sodium. Okay, because of your mineralocorticoid effect. Yeah, so you will have hyponatremia with hyperkalemia. You all understand, right? The effect of your mineralocorticoid. Okay, so hyponatremia in primary is because of that. Where else in secondary adrenal insufficiency, your hyponatremia is more of a dilutional effect. Dilutional effect, because you might have some kind of because of decrease in cortisol. You will have decrease in because cortisol have some permissive effect on the water excretion as well. Okay, so because you lost of that permissive effect, you tend to have slight retention of water, which cause dilutional. So it's more of a dilutional thing, you know. It's more of a dilutional hyponatremia instead of losing salt. you are not losing salt, but the hyponatremia is because the sodium, because there is slight increase in water, so it becomes dilutional. Okay, so you can have hyponatremia in both, but again, hyponatremia is more significant in primary adrenal insufficiency because of loss of sodium in the urine. Okay, hypoglycemia is because of the effect of your glucocorticoid, so it happens in both. Okay, and anemia again also is because of dilutional effect. Okay, so hyperpigmentation you only have in primary. Okay, why? Anyone can explain?
Because in primary we have the destruction of the gland, right? So ACTH will not be able to act on the gland and will have decreased cortisol. So there'll be no feedback mechanism. So we'll have increased ACTH. And in the process of forming ACTH, you end up forming your MSH as well. Mm-hmm. So there'll be increased MSH, which acts on the receptors, and that causes hyperpigmentation.
All right. Okay. So you have to understand the pathophysiology of hyperpigmentation in high ACTH. Okay, so in Cushing's as well, this is also applicable to Cushing's. Okay, in Cushing's syndrome versus Cushing's disease. Okay, in Cushing's disease, you will have hyperpigmentation. In ACTH independent Cushing's syndrome, you don't have hyperpigmentation. So whenever you don't have increase in ACTH, you don't have hyperpigmentation. You should be able to know how to discuss the mechanism of hyperpigmentation due to increased ACTH. Okay? All right. So salt craving, okay, you have in a primary adrenal insufficiency, again because of you lost salt, loss of salt. Okay, so somehow when your salt level is low, you have this symptoms what we call salt craving. Okay, so because of salt losing is occur only in primary adrenal insufficiency, so you have salt craving only in primary adrenal insufficiency. Okay, and also you have hyperkalemia. So these are because of your mineralocorticoid. Okay, so secondary adrenal insufficiency, you have on top of that, you have other symptoms of hypopituitarism. Okay, so that is the difference. Okay, you will, okay, so I have one notes here to say, just to explain which hormone is responsible for which symptoms. This is just for your reading. Okay, I think you will explore more when you do your PBL later. So I don't want to go in more detail than this. Okay, I will leave it to your further reading. Okay. In fact, I have put so much notes for you. This is spoon feeding. Okay, this is hyperpigmentation. Okay, so you have hyperpigmentation on the scar, on certain area, okay, in the buccal mucosa, on palmar creases. Okay. Okay. So we've talked about ACTH stimulation. High urea is because of dehydration, because losing water in this case. So this case is due to primary adrenal insufficiency, right? So you have loss of water. Okay, you can have dehydration. Okay. What is this? Increase into okay. All right. So these are all has been explained. So I have also talked about ACTH stimulation test, synectin test. Okay, so in normal person, you would expect the cortisol. Okay, so remember ACTH, you measure your cortisol. Your cortisol should be increased by 220 nanomole. So there are certain level of increment that you would expect. So remember, so just now with the result, you see some increment, but it's only increment of only by 10 nanomole per liter. So it is considered subnormal. Okay, so subnormal response indicates adrenal insufficiency. Okay, so that can be primary or secondary. So if you want to know whether it's primary or secondary, you want to look at the ACTH level. Okay, another important thing about adrenal insufficiency is adrenal crisis. Okay, most of the patient with adrenal disorder, adrenal insufficiency, if it is caused by adrenal tumor, for example, or because of autoimmune disease, usually the signs and symptoms are gradual, or maybe they are actually asymptomatic, because along the time, they can actually get used to the difference, to the changes, the stress and whatnot. Okay, so sometimes patients with adrenal insufficiency are asymptomatic until they will first present with adrenal crisis. So adrenal crisis is when you have a severe form of attacks of adrenal insufficiency. So you will have severe hypovolemia, shock, and hypoglycemia. Okay, so this crisis is precipitated by stress. When we say stress, it can either be due to infection, trauma, or surgical stress. Okay, it's not stress because stress you want to go for exam. Okay, when we say precipitated by stress, it's probably intercurrent illness, infection, trauma, or surgery. So this is when the patient can, with not known to have adrenal insufficiency, will straight away come with symptoms of adrenal crisis. Okay. Or in patient who is already so in patient who is known to have adrenal insufficiency, okay, so they are put on steroid treatment, okay, but when there is stress, when there is stress, there is failure in increasing the dose. So that means when even in a patient who are known to have adrenal insufficiency, so let's say they are on steroid, so you always need to advise the patient to make sure when you are having fever or whatever, you might need to increase your dose, okay? Because otherwise you might go into adrenal crisis. Okay, so this is one important emergency condition of adrenal insufficiency. Otherwise, if we talk about the case just now, it is not an emergency case, it's gradual. Okay, so other cause of adrenal crisis is when there is hemorrhage to the adrenal gland. Okay, for example, in patients on anticoagulant with bleeding disorder, so you can have sudden hemorrhage, so you can have bleeding into the adrenal gland or infarction to the adrenal gland. Okay, so in sepsis, patient with sepsis, so these are among the cause of patients who are not known to have adrenal insufficiency, but they can develop adrenal crisis. Okay, all right. Again, I have notes for you on the difference between primary and secondary adrenal insufficiency for your reading. All right. Okay, how much time do we have? Half an hour. Very, very quickly. We have hyperandrosteronism and we have pheochromocytoma. Okay, so the third case here is hyperaldosteronism. Okay, is a case of 35-year-old woman found to have a blood pressure of 190 and 110. It's like a very, very high BP. Okay, when the patient came for a routine health check. So this patient, a young lady who we do not expect to have hypertension, come for a routine health check, was found that the BP was very high. Okay, so she was given diuretic, thiazide diuretic, and a week later, she came back and she complaining of muscle weakness. Okay, muscle weakness and constipation. So further investigation, so the doctor suspect that this patient, because of muscle weakness, constipation, on diuretics, so the doctor test for the potassium, it was found that the potassium was very low. Okay. So and diuretics was stopped and the blood pressure, so they changed to the other BP medication. Okay. So, and the patient was started on the potassium supplement. So after 3 weeks, they repeat the potassium and it showed that the potassium is still quite low, 8.6 to 3. Okay, so and it is found that there is a high in urinary. Okay, so urinary potassium was 70. So that means this patient has loss of potassium from the urine. Okay, so the patient was admitted for further investigations for Conn's syndrome. Okay, so with the result of low potassium, high BP, low potassium. Okay, so the patient have Conn's syndrome. Okay. Further investigation, what was checked? So further investigation for Conn's syndrome. Okay, so they checked serum aldosterone, which was found to be high, and renin activity. Okay, which was found to be low. So what does this indicate? High aldosterone and low renin. Anyone?
Primary hyperaldosteronism.
Yeah, primary hyperaldosteronism. You have to understand the concept of aldosterone-renin ratio, because when in the investigation of hyperaldosteronism, okay, so when you find a patient, the aldosterone was high, you have to look at the aldosterone-renin ratio to see whether it's primary or it's secondary. Okay, so in that sense, you have to understand the renin-angiotensin aldosterone concept. You learn that in physiology? The regulation of renin-angiotensin system?
Yeah.
Yeah, okay, so you have to apply that concept. So in this case, so this is just a screening. Okay, screening shows hyperaldosteronism with low renin. So with that, the aldosterone-renin ratio is high. Okay, so this indicates that's primary hyperaldosteronism. Okay, because if in secondary hyperaldosteronism, meaning that aldosterone is high because of other causes. So what causes high aldosterone is actually what can cause high aldosterone besides your adrenal is actually your renin. Okay, so secondary hyperaldosteronism is anything that cause increase in renin, which lead to increase in aldosterone. So in that case, you will have high in both aldosterone and renin. Okay, so your aldosterone-renin ratio won't be high. Okay, so that is the difference. So in screening, it shows that this patient is having primary hyperaldosteronism. Okay, so this is just to show the physiology of it, renin, angiotensin, aldosterone. I'm not going to go further into this. I assume you all have understand this already. Okay. What is okay? All right. So primary hypoaldosteronism, specifically, is called Conn syndrome. Okay, Conn syndrome refer to primary hyperaldosteronism. Okay, so if hypoaldosteronism, secondary hypoaldosteronism, we don't call it Conn syndrome. Conn syndrome refers to increase in aldosterone independent of your renin angiotensin. Okay, so most of the time is because of aldosterone secreting adenoma. Okay, so it can be caused. It is a primary cause from your adrenal gland. Okay, so it can be either adenoma or hyperplasia. So if hyperplasia is bilateral, is adenoma is unilateral, or it can also be carcinoma. Carcinoma is usually okay. So the usual finding is like the case that was presented. Usually, patient comes with hypertension, which was not usually is not young patient with hypertension, which is not reduced with medication, with hypertensive medication, and on top of that, it is there is low in potassium. Okay, so patient have hypokalemia. Your sodium, it can be high, or it can be normal. Okay, because the thing, if your kidney is okay, actually, if you have sodium retention, you tend to also preserve. You tend to also preserve water. Okay, so somehow you don't quite develop hypernatremia so much, but you can have hypernatremia. Okay, but what's important is hypokalemia because you lost potassium. Okay, so muscle weakness because of low in potassium. Okay, muscle weakness, paresthesia, all this ECG finding, this is all because of hypokalemia. Yeah. Okay. So the difference in causes can be primary and secondary. So we talk about primary adenoma, hyperplasia. Okay, so hypertrophy of zona glomerulosa cell. Okay, so that's why it affects. So when you talk about adenoma, it's adenoma of involving the cells in the zona glomerulosa, and you can also have somehow hypertrophy of the zona glomerulosa. So that's why it's only aldosterone which is involved, not your glucose. Okay, so the secondary aldosteronism is because of increase in renin. Okay, so what caused increase in renin is there are few renin is stimulated by decrease in blood pressure, right? When there is decrease in intravascular volume. Okay, so causes of this can be either heart failure, nephrotic syndrome, in which you have lost your effective blood volume in the vessels because of ascites. You know, when you have cirrhosis also, all these three causes, you have third, like congestive heart failure is a decrease in cardiac output. Okay, so increase in renal angiotensin. Cirrhosis, you have ascites. Okay, when you have ascites, you have increase in volume going to the third space, so your intravascular volume is actually low. The same with nephrotic syndrome. Okay, so others are renal angiotensin. So all these are leading into increase in renin. So you have increased renin, increased aldosterone. Okay, so you should understand the difference. Okay, so clinical features, we've talked about this. So what has this got to do with diuretics? Okay, so in this case, the diuretics, which the loop diuretics that is used, are also causing hypokalemia. So it causes loss of sodium, and at the same time, it causes loss of potassium. Okay, so that's why it actually further decrease your potassium. So you have to be very, very careful in a patient with hypokalemia, hypertension, hypokalemia. You want to make sure the hypokalemia is not because of diuretics. So in this case, patient was given a diuretics. So it is assumed initially. So because of this diuretics, thiazide diuretics, the hypokalemia gets worsened. Okay. All right. Okay. So we have talked about the investigations actually. Okay. So investigation, we talk about screening. We look at the aldosterone renin ratio. If it is high, it's primary. If it's not high, then it's secondary. Okay, then you can do to diagnose further. We can do dynamic test, which in this case we can do saline infusion test. Okay, so we want to, because it is hyperaldosteronism. Okay, we want to try to suppress the aldosterone. Okay, so how do we want to suppress the aldosterone? We want to suppress the renin. So in this case, we give saline. Okay, so we actually want to give sodium loading. So sodium loading, in this case, we give saline infusion. Okay, so when you give sodium, you will suppress your renin. Okay, so in that case, you want to try to suppress your aldosterone. Okay, so in hyperaldosteronism, okay, your plasma aldosterone will remain high. Okay, so in a hyperaldosteronism, your plasma aldosterone your plasma aldosterone will remain high. Okay, because it cannot be suppressed. It is not related to your renin. It is produced due to tumor. Okay. Okay. So otherwise, if it is secondary, then you might be able to suppress the aldosterone, because now you are suppressing your renin. Okay, you are suppressing your renin. Okay. All right. So when you confirm that is primary hyperaldosteronism, of course you want to know whether this hyperplasia or this tumor. So further investigation include imaging investigation. You want to do a CT scan, okay, and you want to see whether there's a mass or not. And at the same time, you want to proceed with selective adrenal venous sampling. So that means you want to measure the aldosterone level in both sides using a venous sampling from right and left. So if it's because you want to see, first you want to identify whether it's unilateral or bilateral, okay, and if it's unilateral, usually it's a tumor, and also you want to look at which side. Okay, so other test is the response of aldosterone to change in posture. I'm not going to go into this further, because this is not done so much, since now they are going into looking at the ratio. Okay, but there is another test that you can do. You look at the aldosterone level when the patient lying down and in the morning, and then and then you take another level when the patient wake up and walk around after a few hours, then you check again. So it has something to do with sensitivity of tumor to ACTH. Hyperplasia is sensitive to renin, and tumor is sensitive. So it is quite complicated. So no need to go so much into that. Okay. Okay, any questions before we move to you? Yes.
Just want to clarify. If aldosterone and renin ratio is high, it's primary, right? But if it's secondary, then the ratio is not high, but still the concentration of the aldosterone and renin is still high, right?
Yes. Yes. Both, because both increase. So but the ratio won't be high.
All right.
Okay, because in primary you have one high and one low. So you expect to have a very high aldosterone renin ratio, whereas in secondary both increase to the same accordingly lah, because aldosterone increase due to renin. Okay, so the ratio will actually remain, but the level of course is high. Any other questions before we move to Pheo? You all have learned Pheo also in physiology, right? So there's a case here is a 55-year-old woman presents with anxiety, palpitation and sweating. Okay, pulse rate is 120, which is high, but it's regular. Okay, and again BP is also high. So remember, in endocrine you will find that a few hormones actually lead to high BP. So far we have learned your aldosterone, your cortisol, your in Cushing's, your cons, your Pheo, all is about increase in BP. Even in acromegaly, your BP is high, right? But BP high due to different mechanisms. Okay? Okay, so this is also very, very high. Okay, she has previously been investigated for abdominal pain. So she has been having abdominal pain before this. Okay, but no finding. Okay, so thyroid function tests are normal because of palpitation and sweating. They test for thyroid, so it was normal. Okay, so the doctor ordered 24-hour urinary catecholamine. Okay, so the doctor now high BP, sweating, anxiety, palpitation. So doctor suspect pheochromocytoma. So test for your catecholamine. Okay, so it is found that what is HMMA? What is HMMA? HMMA is the metabolites, okay, of your adrenaline and your noradrenaline. Okay, so hydroxymethyl mandelic acid, or sometimes it's called vinyl mandelic acid. So if you look at the result here, HMMA is high, adrenaline is high, noradrenaline is normal. Okay, so high in adrenaline, noradrenaline is normal. Okay. Okay, so proceed to CT scan, shows mass arising from the left adrenal gland, and with isotopic scans, okay, shows a single left adrenal mass. Okay, so obviously there is a mass coming from the adrenal gland, and this patient is diagnosed to have pheochromocytoma. Okay, so it differs from your adrenal cortex. Okay, the cells in the adrenal cortex, which are endocrine cells. Pheochromocytoma is a neuroendocrine tumor. Okay, so it arises from your medulla of the adrenal glands. Okay, usually it is benign, and it is originated from chromaffin cells in the medulla. Okay, so this cell secretes your catecholamines, okay, which is your noradrenaline and your adrenaline, your epinephrine. Okay, okay. So the things is pheochromocytoma. It can occur in other endocrine in other places as well. Okay, which has the same origin. Okay, so but most of your pheochromocytoma can be found intra-abdominal. Okay, the pathology is in the abdomen. Okay, so they can come, that's why usually they present with abdominal pain, and you might have abdominal mass as well depending on the size. So most of the lesion you will find in abdomen, and 85% are in the adrenal gland. So that means in the abdominal lesion, you can also have pheochromocytoma, which is outside of the adrenal. Okay, so so you can also find pheochromocytoma or outside the abdomen, which we call along the ganglions, paraganglioma. So this has something to do with the embryonic origin of the cell. So these are the distribution of pheochromocytoma. So that's what we call, so outside the abdomen, we call it paragangliomas, okay? But it acts the same as pheochromocytoma. It secretes catecholamines as well, okay? So others are intra-abdominal, mostly are in from the adrenal glands. Okay, and then so this about 30% of pheochromocytoma are also associated with familial disease, okay, which are a few. I don't want to go into detail, but because I'm only covering just very briefly on pheochromocytoma, but bear in mind when you have pheochromocytoma, you need to also look for other medical condition, which is in this case is von Hippel-Lindau syndrome, MAN2, multiple endocrine neoplasm 2. So you have to also look for other endocrine disorder in that category, and also in neurofibromatosis. Okay. All right. Okay. Macroscopically, okay, it can appear as grossly as a mass, okay, and usually is with hemorrhagic, okay. So some can be, you find it as mostly, like I mentioned, usually intra-abdominal. So some you can be extra-adrenal, okay, usually from your adrenal gland, but there are certain percentage which is in the abdomen, but it is not in the adrenal gland, okay, and microscopically it forms a nest of large cells and vascular stroma. I think Dr. Bushra will go through the microscopic features with you. Okay, as for the sign and symptoms, okay, usually patient will come with hypertension, okay, severe hypertension, and this hypertension can be episodic, okay, it can be what we call paroxysmal, it's fluctuating, okay, so that means it can be sustained meaning the hypertension is there all the time, it can, but it's quite common also that they have episodic hypertension, so it's only come at certain time, okay, so when you start to have hypertension, so you will have severe headache and sweatings and palpitation. Okay, it can be triggered by stress as well. Okay, and it will go to normal. Okay, and so that is also common. We call it paroxysmal hypertension. Okay, it can also be sustained, so that means hypertension is there all the time. Okay, it's associated with sweating, palpitation. These are all because of your catecholamine. Yeah? Hypoglycemia, glycosuria, headache. Okay, so these are the common ones: hypertension, sweating, palpitation, and headaches. Okay, this is how grossly it looks like. If you can appreciate that this is actually adrenal gland. Okay, and this mass arise from the adrenal medulla, so it tend to actually compress the surrounding adrenal cortex. Okay, so this is microscopic, so it's like nest cell. It is described as nest cell, so nest of the clusters of chromaffin cells, which is collected into nests, okay, or alveoli. Okay, these are cortex, and this is your medulla. Okay, so the sign and symptoms, again, classic triad is pounding headaches, palpitation, and diaphoresis. Okay, so you can have hypertension on top of that. Okay, you might have orthostatic hypotension. I don't know why. Okay, but these are the classic triad of your pheochromocytoma. Okay, so triggering symptoms are stress, mainly stress, abdominal pressure. Okay, usually it's stress. Patient with stress or infection suddenly comes with headaches, palpitations, and tachycardia. Okay. All right. So these are the pathophysiology of signs and symptoms. I think you can read. The main one is the effect is all because of catecholamine excess. Yeah, catecholamine excess. Okay. So this one is notes for you that you can read. Okay. So as for the investigation, you have to again refer, just to show here the metabolism and synthesis of your catecholamines. Okay. It comes from dopamine. Okay, thyroxine. Okay, which is transformed into dopamine, and dopamine is further converted into adrenaline, and noradrenaline. So in pheochromocytoma, you can have dopamine secreting pheochromocytoma, adrenaline secreting chromocytoma, and noradrenaline secreting pheochromocytoma, or you can have both. Usually you can have one more predominant than others. Dopamine secreting pheochromocytoma is very rare, but you can have that. Okay, so if you refer to here, you see your noradrenaline and adrenaline is further metabolized into other metabolites. So in a lab, you can actually measure epinephrine, okay, adrenaline and noradrenaline, and in this case we measure this and this and this one. Okay, we measure noradrenaline, adrenaline, and VMA, your HMMA. Okay, but nowadays, because it is found that your adrenaline are actually more sensitive and more specific, so the metabolites are also used as a measurement for investigation of pheochromocytoma. Okay. Any question on pheochromocytoma? Before we go briefly on congenital adrenal hyperplasia, actually I don't intend to go in a great detail. Okay, only 2 slides, only 3 slides. Congenital adrenal hyperplasia is another category that is under adrenal disorder. Okay, so it is an inherited, so it can be adrenal insufficiency plus so it can so it in CAH, congenital adrenal hyperplasia, you can have hyperactivity as well as hypoactivity. Okay, because due to enzyme defect. I show you earlier in the pathway. It can be caused by a few enzyme deficiency. It can be so, but what I want to emphasize here is only one enzyme deficiency, which is 21-hydroxylase deficiency, because this is the most common cause of CAH. Okay, so in defect in enzyme, in this enzyme, in 21-hydroxylase deficiency, so you will have increase in 17-hydroxyprogesterone and increase in androgen. So you will have a patient, usually female patient, with masculinization. So you will have babies, female, okay, born with ambiguous genitalia. Okay, and as they grow, they will have hirsutism. Hirsutism are the androgen effect on women. They will have facial hair, you know, and they will have so, and they, as they grow older, they will have amenorrhea and fertility. So in babies, they can present with ambiguous genitalia, and in adult, they can grow up with hirsutism and amenorrhea. Okay, so that is in female. In male, usually it will present later. It will present later when the baby grow a bit with precocious puberty. So that means a boy who develop puberty at early age. Okay, so in male. All right. So the enzyme deficiency can be partial or can be complete. Okay, so if it complete deficiency, okay, it can be life-threatening at birth. Okay, because of insufficiency of aldosterone. Okay, and insufficiency of aldosterone as well as cortisol. So I show you. Okay, if you refer here, okay, I show you earlier. Okay, the 21-hydroxylase deficiency. Okay, so you will have decrease in aldosterone as well as decrease in cortisol. Okay, so at the same time, you will have accumulation of your 17-OHP. So because of accumulation of your progesterone and this, so it will go to here. It will cause increase in androgen and so you will have hyperandrogen. So we'll have hyperandrogenism. So the effect is mainly will be more on female rather than male, you know, because in male there is testosterone, but in male they will have precocious puberty. Okay, so if this is partial, then you will only have mild effect of low in aldosterone and cortisol. So it might not be life-threatening, but if it is a complete blockage, so it will be life-threatening. Okay, so you will have you will have hypotension, salt losing, okay, and hypoglycemia. All right, so you will have like adrenal crisis kind of sign and symptoms. Okay, all right. So this just show you what I meant by ambiguous genitalia. Okay, so it's a baby girl born with genitalia looks like this, very big clitoris. Okay, so fused labia. Okay, so this is CAH. Okay, I think that's all for adrenal deficiency. Any questions? So I hope you understand the concept and can go back and read. Okay? because we only have 2 hours, it's highly impossible for me to go through everything. But I think I have highlighted what you need to understand. So you have to go back and read further. Okay? Any questions? How do I go back to the page? Okay, any questions? Oh, Akmal, sorry, the attendance.
Oh, all right, bro.
Okay, so can we end this session if there's no question? Yes, no? All right, so so you will be on a 1-week holiday, yeah, after this?
Yeah.
Okay. All right. So so I guess we end this session. Okay. So remember again, so I hope you are all aware of that online online examination. We have no choice. We have to proceed with online examination. For now, I think hopefully by 9th of June, you all can come back to campus. By all means, we can conduct a face-to-face examination, but don't hope so much for that. That is why, because we don't have much time, so we have decided to proceed if the MCO extended, we want to proceed with online examination. So I think all the lecturers are already prepared for online examination, and we are interacting also with the IT people for them to share their experience with other faculty, because other faculty has conducted online examination. So we want to try to find a way to sort some solution to those with slow internet. So I think so far there is not so much problem with other faculty. So